Yeah, good day everyone. My name is Onowori Victor. I am a neurology applicant and I will be doing the Cheng Cheng's Comprehensive Review in Clinical Neurology. So this is chapter 2. We've done chapter 1, which was neuro-ophthalmology and cranial nerves. We did about 1 to 73 questions, and well, it went well and good. For this chapter, I have done a little upgrade. So, one, I got an external microphone which helps with noise cancellation. Hopefully, when I listened to my previous episodes, the first chapter, I discovered that there were a lot of background noises that could actually interfere with learning. So I had to purchase this. Then, secondly, I am also using the Audacity app. So rather than recording from my phone, I decided to use the Audacity app, which seems very handy. This is my first time using it, so let's see how it goes. So that being said, we're going to be doing chapter 2, which is vascular neurology. We'll be doing 1 to 5 questions daily, but if the spirit leads, we may do more than 5 questions. So let's begin with question 1. We have a 65-year-old patient with diabetes presents with a transient ischemic attack, that's a TIA. According to the ABCD2 score that assesses stroke risk in someone with TIA, which of the following is not used as a predictor of occurrence of a stroke? So we have A, diabetes, we have B, age of 60 years or more, we have C, hypertension, D, duration of neurological symptoms, and E, hyperlipidemia. Looking at these questions right off the bat, I will probably just pick options E, which is hyperlipidemia. But then let us dive into what a TIA is and the assessment of a TIA as regards to stroke risks. So a TIA basically means a transient ischemic attack, and it's actually a medical emergency. It is defined as a transient episode of neurological dysfunction which is due to focal brain, spinal cord, or retinal ischemia without an acute infarction or tissue injury. Now, the definition has actually moved from a time based definition to a tissue based definition. And typically, a TIA lasts for less than an hour. Most often than not, TIAs usually occurs within minutes and resolves after some minutes. It's usually a very serious warning of an impending stroke, and usually the risk of a stroke is usually highest within the first 48 hours following a TIA. So you need to be able to predict whether or not this patient is at high risk for getting a stroke when the patient has a TIA, and thankfully we have a scoring system that helps with this prediction called the ABCD2 scoring system. Now, the ABCD2 scoring system basically is an acronym for age, blood pressure, clinical symptoms, diabetes, and duration of symptom. So the D, there are two Ds, which is why we have the D2. Now for age, if a patient comes in and the patient is more than or equal to 60 years of age, you give a score of 1. If not, you give a score of 0 in the presence of a TIA. 2. If the patient who has this TIA like symptoms has a blood pressure of 140 over 90 or more, you give a score of 1. Next, if the patient comes in with clinical symptoms, including speech impairment with no focal signs or no focal weakness, so you give a score of 1. But if the patient actually has focal weakness, you give a score of 2. Now, for duration of symptoms, you give 1 point for symptoms that are less than 60 minutes, that is symptoms between 10 minutes to 59 minutes, and you give a score of 2 for symptoms that occur for more than 1 hour or symptoms that occur for more than 60 minutes. And lastly, for diabetes, if a patient comes in with CIA like symptoms or stroke like symptoms, the patient actually has diabetes, you give a score of 1. So, like we said, the highest risk of stroke occurs within 48 hours, and if a patient actually has a score of 0 to 1, then the risk of score of a stroke is actually 0. And if a patient has a score of 2 to 3, the risk of stroke becomes 1.3%. A score of 4 to 5, the risk of stroke becomes 4.1%, and a score of 6 to 8 gives you a risk of 8.1%. Now, with that being said, we've seen that hyperlipidemia is not a part of the ABCD2 scoring system as seen in options E, which is our question. So, back to our question, like we said, options E is the answer. So, on to the next question, question 2. So for our next question, number two, a 42-year-old woman with diabetes, hypertension, and hyperlipidemia is brought to the emergency department for unresponsiveness. An MRI was obtained and is shown in figure 2.1. Let's take a look at our MRI. So if you look at the caption, what's written here is figure 2.1, axial diffusion weighted MRI. So this is DWI. So which of the following will most likely be encountered in this patient? A. Vertical gaze impairment. B. Hemisensory symptoms. C. Hemiparesis. D. Quadriplegia with impaired horizontal gaze. And E. Aphasia. So, let's not pick an option yet, like we did in question one. Let's first explain what this MRI shows us, and then let us then try to decipher our patient's symptoms. Okay, so let's take a look at our MRI. Look at this MRI. When you take a look at this MRI, what do you see? So, basically, I can see some areas of restricted diffusion. I mean, those areas actually stand out pretty well. When we say areas of restricted diffusion, usually in a DWI, if you see areas that are very hyper intense, it means there's most likely an ischemic change in that area. But before we even go into that, let us first find ourselves. Where are we in this brain? This is actually our pons. This is our cerebellum. This here is the fourth ventricle. This here is our pons. These are ventral pons. So you can see this area of restricted diffusion in the ventral pons. We can see also some areas of restricted diffusion in the cerebellum. So this patient is going to have very interesting symptoms. Not interesting for the patient, but interesting for us. This patient is most likely going to have locked-in syndrome, and it's a constellation of symptoms. One classical thing about locked-in syndrome is the fact that the patients are usually quadriplegic and they have an impairment in their horizontal gaze. And why would they have impairment in their horizontal gaze? This is due to the fact that we have a damage to the ventral pons, and that is going to affect the paramedian pontine reticular formation, the PPRF, which is our horizontal gaze center. So if this area is actually damaged, then you will have issues, moving your eyes left and right. Um, Also, there is going to be damage to the corticobulbar tract that carries the motor commands to cranial nerves that are involved in eye movement. Now, on the other hand, vertical gaze is usually preserved, and that is because of the fact that vertical gaze is controlled by the midbrain, which is actually above the pons. So, since this lesion did not affect the midbrain, we are only giving the lesion in the pontine region. That means that the MLF is not going to be affected. The medial longitudinal fasciculus, which actually helps us in our vertical gaze, we call it the vertical gaze center, which is located in the midbrain. That's not going to be affected. So that being said, let's go back and then let's see our options. So for option A says vertical gaze impairment. So we said now unlikely. How will it be unlikely? Because vertical gaze center is in the midbrain. So we have hemisensory symptoms. Now, if you take a look at the MRI, you will see that there is actually a bilateral lesion. So it's unlikely for you to have hemisensory symptoms. It's going to be both parts of the body that will be affected, not just half. So hemiparesis unlikely to be hemiparesis, because, like I said, there's bilateral involvement. D. Quadriplegia with impaired horizontal gaze. So that's correct. So our last option is options E, which is aphasia. Now, aphasia can be a very tricky option, in the sense that aphasia is not a feature of the classical locked-in syndrome. So, first of all, what is aphasia? Aphasia basically is a language disorder due to damage to the dominant hemisphere, typically the left hemisphere. So, we can cause something we call the Broca's aphasia or the Wernicke's aphasia. Now, patients who have locked-in syndrome appear mute. We call that an atria, and they are paralyzed, and this can be mistaken for aphasia. But it should be noted that they are conscious, they are cognitively intact, and they can communicate using vertical eye movement and blinking. So when we say aphasia, we we don't aphasia is not a typical symptom, or aphasia is not a symptom of locked-in syndrome, and their cortex is preserved, so there is no affectation of the area that processes language. So they understand and they can formulate language normally, but they cannot express it vocally due to paralysis. So that being said, we've said that our options D, is the right option. So the next question, question number 3. A 49-year-old man with a history of hypertension presents to the emergency department with acute onset of right hemiparesis and aphasia. The time he was last seen normal was about 45 minutes prior to arrival. The NIHSS score, which is the National Institute of Health Stroke Scale score, is 14. Which of the following is the next best step in management? So, once you see a patient like this who has an NIHSS score of more than 14, the patient came in probably 45 minutes or whatnot, whatever time the patient came in, and the patient actually has symptoms that are suggestive of a stroke, the first thing you need to do is to run a brain CT. CT first before any other thing, right? That's like a classical teaching. But let's look at the options. A, start IV tissue plasminogen activator. B, get a brain CT scan ASAP. That's what I'll go with. C, give aspirin 325 milligram once. D, start IV heparin. And E, get a brain MRI. So this is actually the textbook question. It's something that you should have at the back of your mind. See a patient with symptoms looking like a stroke, high NIHSS score, came into the hospital. First things first, do a brain sitting. Now, this patient's clinical presentation is actually consistent of an acute stroke. And if this is an acute ischemic stroke and there are no other contraindications, what you do is you give the IV tissue plasminogen activator, that's the TPA. Why will you give TPA? Well, this patient actually presented within the window of therapy, which is ideally 3 hours, but it's usually safe if you give it in less than 4.5 hours. Now, but like I said before, when a patient presents to the emergency department with acute onset of focal neurological symptoms that are suggestive of a stroke, and if stable from the hemodynamic and the respiratory parameters, steps should actually be taken in a timely manner because, like we said, or like we always say, the mantra in neurology is time is brain. So the NIHSS scoring system is actually a point system that is used to assess patients presenting with a stroke, in which different neurological functions are examined, including consciousness, vision, eye movement, movement of the face, the arms, the legs, sensation, coordination, speech, and language. And we give points to this score, or we give points to each parameters, and the maximum score is 42. So the higher the score, um the more severe the stroke is, and the worse the prognosis, or the worse the neurological deficit. Now, in a patient who presents with acute neurological symptoms, the first thing you should do is to obtain a brain CT scan, and why you want to rule out an intracranial hemorrhage. Now, a brain CT scan will also help us to know if there are other structural lesions or any already established ischemic changes. So if there's no evidence of hemorrhage, and you are fine with the brain CT, the next thing you need to do is to now get um, the exclusion criteria checked out. So, if there are no contraindications to a TPA and the patient is still within the time window of 4.5 hours or 3 hours, you can give the TPA. Now, the dosage for the TPA, that outer place, is 0.9 milligram per kg. And usually, how is it given? You give 10% as a bolus, and then the rest over 1 hour. And the maximum dosage of this TPA, or that's outer place, is 90 milligram. Now, you should note that in places with low resources, they may not be able to afford outer place. So, the alternative to use is tenecteplase, and tenecteplase is given at 0.25 milligram per kg with a maximum dosage of 25 milligram. So the time window for IVTP administration, approved on the basis of the National Institute of Neurological Disorders and Stroke (NINDS) TPA trial, is 3 hours, and based on the European Cooperative Acute Stroke Study 3, that's the ECASS3, IVTPA is safe and beneficial up to 4.5 hours after the onset of symptoms. So some people say that between 3 and 4.5 hours of onset of symptoms, additional exclusion criteria for IVTP administration includes age more than 80, NIHSS of more than 25, the use of anticoagulants, and a combined history of stroke and diabetes mellitus. But you see that the recent guidelines have said that age more than 80 is no longer an absolute contraindication, rather, it is a relative contraindication. And for older adults, especially those more than 80, if they were functionally dependent before the stroke and they present within the 3 to 4.5 hours stroke window, the risk to benefit ratio actually favors treatment in many cases. Then for NIHSS score of more than 25, like the previous discussion, this is also a relative contraindication, and these are due to concerns about symptomatic intracerebral hemorrhage, lower likelihood of good functional recovery, and large infarct core that are already present. But studies have actually shown that patients with very severe strokes still benefit from thrombolysis despite the higher risks, and this decision should be based on the time from onset, the imaging findings, basically the aspect score and the sign of a large infarct, and the baseline functional status. Now, aspirin may be given if IVTPA is not administered. However, a CT scan is a priority to rule out an intracranial hemorrhage. So, for our next question, question number 4, a 49-year-old woman presents with acute onset of hemiplegia progressing to quadriplegia over the next 2 hours. On examination, she seems awake. However, she is unable to verbalize and has increased oral secretions. She cannot move her eyes horizontally, but is able to move them vertically and blink. So we've just talked about this in our previous question, 2 questions ago, where we talked about a patient who had locked-in syndrome. So this is classical for locked-in syndrome: inability to move the eyes horizontally, but the ability to move it vertically. So which of the following is the most likely cause? So we have A, bilateral thalamic infarct, that's false. B, lateral medullary infarct, that's false. C, top of the basilar occlusion, nope. D, infarct affecting the base of the pons bilaterally, true. And E, an infarct affecting the dorsal midbrain. So we've already talked about that, but I think it's just best we do a little more talk about this so we can clear up locked-in syndrome. So, like we said, this patient had locked-in syndrome, which is caused by an occlusion of the basilar artery, leading to bilateral infarct of the base of the pons, and this will affect very critical structures that are involved in motion and in movement, including the lung tract. But consciousness is preserved because of the lack of affectation of the reticular activating system. So generally, these patients are usually awake. They have their consciousness preserved. They can blink and they can move their eyes vertically. However, they are quadriplegic. They are unable to speak, and they have impairment of horizontal gaze or horizontal eye movement. Like we said, due to the affectation of the PPRF, the paramedian pontine um, reticular formation. So there's a very interesting option. Top of the basilar artery. It's we call top of the basilar syndrome. Basically, it results from an occlusion at the top of the basilar, and it comes in with a variety of clinical symptoms. Now, it leads to infarct of structures above the basilar artery, which includes the midbrain, the thalamus, the temporal and occipital lobe. And like we said, the manifestations are usually very complex, and they are varied. So you could have behavioral abnormalities, alterations in consciousness, pupillary manifestations, disorders of ocular movement, visual eye deficit, motor sensory deficit, and you can name it. Yeah. So this option is actually wrong. It can be tricky because occlusion of the basilar artery leads to a locked-in syndrome. But when we have an occlusion of the top of the basilar artery, you get something unique called the top of the basilar syndrome. Okay, good. Now, so the next question, which will be our last question in this particular video, since we said we're doing questions 1 to 5. So, question 5: which of the following is correct regarding thrombosis of the venous sinuses? So A, diplopia with cis-cranial nerve palsy is specific for cavernous sinus thrombosis. Okay, so now first of all, let's debunk this. If you watched our previous video in the very first chapter, one of the videos, we said something about the fact that cis-cranial nerve can have a palsy due to an increased intracranial pressure, and that's because the cis-cranial nerve actually has the longest intracranial course. It is the thinnest of the cranial nerves, and it actually lies on the petrous portion of the temporal bone. So, if you have an increased ICP, that can actually compress the ciscranial nerve, and that will lead to ciscranial nerve palsy. So, it is not a ciscranial nerve palsy is not specific for cavernous sinus thrombosis. Rather, it is seen in increased ICP. So, B, headache is present in less than 50% of cases. This is so false. Reason being that headache is present in more than 90% of cases of patients who have thrombosis of the venous sinus. Now, C, increased intracranial pressure is uncommon. That is false. In fact, a vast variety of patients will have increased intracranial pressure. D, superior sagittal sinus thrombosis may produce bilateral thalamic infarct. Now, for you to have a thalamic infarct, venous infarct, it has to be thrombosis of the deep venous sinuses. So usually a superior sagittal venous sinus will cause an infarct in the parasagittal cortex, and basically you actually have an infarct to the areas that are supplied by this anterior cerebral artery. So you may have contralateral limb weakness, lower limb weakness, sensory losses. You may have urinary incontinence, ebulia, which is lack of will or initiative, and whatnot. So D is off. Then E, seizures are more common in venous infarct as compared to arterial infarct. Now, this is so true, and let's talk a little bit about it. Now, seizures actually occur in about 40% of patients with venous sinus thrombosis, which is a higher percentage than even patients who have an arterial stroke. And in patients with the venous thrombosis, headache, like we said, is the most frequent symptom and is actually seen in about 90% of cases in adults. Now, due to the fact that there is an occlusion of the venous drainage alongside with hemorrhagic infarct and edema, patients will generally have an increased intracranial pressure. They may also have diplopia, which is caused by the sixth nerve palsy, and this is non-specific and has non-localizing value and may be a manifestation of an increased ICP. So that brings us to the end of this episode. I look forward to doing more in the next episode, and I'm going to judge my microphone and this current app and see whether or not it's worth the investment. Thank you, and have a lovely day ahead.